We're all human. And it's important to know that doctors are people too. Doctors have emotions, they have passions in life and hobbies, and they enjoy participating as active members in the communities where they practice medicine. Doctors have families, friends, and relationships. While the latest in healthcare and the most current treatments for ailments will be topics on this Doctors Are People Too radio TV show, the focus will be in learning more about the interesting aspects in a physician's life and what they do away from the doctor's office or operating room table.
Good evening, South Florida. My name is Patty Villa, and I'm in for Dave DiPino, who's off this evening. Tonight, we have with us our first guest, Dr. Miguel Diaz from Palmetto General Hospital. Good evening, Dr. Diaz.
Hi, Patty. How are you?
Good. How are you doing?
Great. Thanks for having me.
Thank you for coming on with us for a few minutes. I know you have a procedure to do, but we want the community to be informed. We know you were instrumental in bringing the Abbott absorbable stent to Palmetto General Hospital. Can you tell us exactly what that is?
So sure, that's a scaffold they're being called now. It's a bioresorbable vascular scaffold. So traditionally we would put in blocked coronary arteries, we would open those arteries and prop them up with a metal scaffold called a stent. Those stents evolved over the years, and lately we've been having what's called drug-eluting stents, second-generation drug-eluting stents. So they're very advanced and doing very well, but at the end of the day, there's always a piece of metal left behind in the artery. So kind of the last frontier probably for treating coronary blockages is to be able to have a device that opens the blockage, treats the coronary artery disease, but doesn't stay around forever. And when it's done its job, it dissolves and goes away. And so Abbott has, through a tremendous amount of research and clinical trials, been able to come up with a device, and they're first to market that does just this, and it's called the Absorb BVS. BVS stands for Bioresorbable Vascular Scaffold.
And what type of person is a candidate for this procedure?
So we have it in our cath lab. We're on one of only 2 cath labs now in town who have it, and we approach each patient individually. And so first and foremost, it's a patient that would require opening a blocked artery. So the same type of patient that we would place a coronary stent in today or yesterday, now we just have another option in our toolbox. And so there are certain patients that we treat with the older stents that are not good candidates for this new technology, namely patients who have small vessels or heavily calcified vessels or very tortuous or angulated vessels. But when you come upon an artery that needs to have a scaffold placed and meets the criteria of being a fairly large vessel, not at a bifurcation point, which is a fork in the road kind of for an artery, and meets a couple of other criteria. If they're a good candidate, we go ahead and we put them in just like we would put in any other stent.
And if I remember correctly, I remember you telling me a story that you went and you heard a lecture from the gentleman that created this stent. Is that correct?
Well, we recently had the opportunity to have a conference given by Dr. Schatz. So Paul Maz and Schatz were the two docs who Paul Maz was a radiologist and Schatz was a cardiologist, and they developed the first stent that was implanted in human beings. And Dr. Schatz was kind enough to come to Miami recently and give a conference that I was fortunate enough to be invited to, and so it was a tremendous history lesson in seeing how far we've come from those early days, which in and of itself was a monumental step forward to where we've come today. And I do think that this is probably the beginning of the last frontier as far as being able to treat coronary disease with the best of both worlds. A scaffold that is strong enough to keep the artery open, but that once it's done its job, it dissolves and goes away.
And I know you've done several of these cases already in the last few weeks. And when you have a patient and you do this type of procedure and you tell them that this disappears, basically, it's like magic in 3 years, what is it that the patient's reaction have been?
Well, it's been very positive. Obviously, there's always concerns about stents long term, although the general results have been excellent and continue to be excellent. us as physicians and patients themselves always kind of have in the back of their mind that they have a permanent piece of metal in their stent, in their artery. And if you can tell them that that's not going to be the case in a few years, and the artery will return back to its normal state and its normal, what we call vasomotor activity, meaning it can dilate, constrict, bend, and do all the different types of movements that arteries normally do. Certainly patients, they feel very, very happy about that. They feel a sense of comfort when they hear that.
And you're seeing, I know you did a procedure, a MitraClip procedure on a young woman that was 49 years old. When you do these types of procedures on people that are in their 30s and 40s, what is it that you're teaching them or educating them on? Because it seems to me that we're seeing cases of people younger and younger having these types of complications.
Yeah, so with regards to the scaffold, the BVS, I think younger patients certainly are a more attractive subset for this kind of therapy because they're going to have the disease longer. They're going to be around longer. So if you were to put a metal stent in a young patient, they would have a stent in place for the duration of their life, and the duration of their life obviously is going to be much longer than an older patient. And so the ability to put in a scaffold that dissolves over a period of a couple of years is even more attractive in younger patients. And then you're right, we are seeing, unfortunately, heart attacks at young ages for many reasons, both the obesity epidemic, the diabetes epidemic. We're seeing here in our patient population around Hialeah, we're seeing a significant increase in smoking. And so due to all those reasons, we are seeing a lot of younger patients having disease, and this is a great technology to be able to offer them.
And when you have these young patients come to your office and you talk about different options, what is the advice that you give to these patients?
Well, first and foremost is to ask questions and to get educated. And certainly I encourage second opinions and third opinions. I think the more informed our patients are, the better they can make decisions for themselves, and the better that we can help them to make decisions. But as far as how I approach this technology, I kind of do tell them the pros and the cons, and there are both. The pros I think we've talked about. The cons involve the fact that it's still a new technology. There's still a lot of information that we have to learn. There is some signs in the data that it's not probably great for small vessels. It looks like when you try to put these scaffolds into small vessels, the chance of them clotting up and closing is higher than in the stents that we use normally. So what I tell them is that it's not for everybody, and that we won't really know if they're a good candidate for it until we're in the cath lab making the decision, and we really try to make that as a group decision.
And that was actually my follow-up question, because something I've learned at Palmetto General Hospital is that there is a team approach and that there's several doctors that work together. I know you've worked on some cases with Dr. Manny, and everybody collaborates. So tell me, so the audience understands, how positive is it to interact and have that team approach with the patient?
Well, definitely. We have moved, I think most of cardiology over the last few years has moved into the heart team approach, as opposed to just the cardiologist and his or her patient. We've moved more into a multidisciplinary approach. So for example, when we do our structural heart procedures, which include TAVR and the mitral clip procedure, we have cardiologists, interventional cardiologists, we have cardiac surgeons, cardiac anesthesiologists, nurse practitioners. We have certainly our cardiology fellows, which are invaluable to us. They keep us young, you know, Patty.
Yes, they sure do.
So, it's a bunch of people putting in their 2 cents and making the discussion more robust and keeping everybody on their toes and making sure that we're really turning over every stone and making sure that the final decision that we're making and the final treatment that we're offering is the best that we possibly can.
And let me ask you my last question, because I know you have to go off and do a procedure, is what is it that you want people to know about Palmetto General Hospital being in the heart of Hialeah, that we have so many different wonderful things going on in all the different service lines?
Well, I think that people I think first and foremost, for those who have been here for many years, should know that Palmetto is changing rapidly. I think we are growing. I think Palmetto has a lot to offer in regards to sophisticated technology and state-of-the-art treatment. This is not your grandmother's Palmetto. Let's put it that way. I think we've really grown tremendously over the last 5 years, and we really have our sights set on developing our programs tremendously, so that there is no need really for any patient to leave the Hialeah area in order to receive complete cardiovascular or neurovascular care. We can offer it all here.
I couldn't have said it better myself, Dr. Diaz. Thank you and have a good night.
Okay, Patty, thank you for having me.
Thank you. And I just wanted to say, if anybody wants to learn more about the Abbott stent, they can call 844-319-3978. That number again is 844-319-3978. We have designated, Palmetto General Hospital has designated its own number to the Abbott absorbable stent. This is how important it means to our CEO, Ana Mederos, and the entire A team. Our second doctor that called in this evening is Dr. Dominguez Bali. And he is with Hialeah Hospital. He's an OBGYN. Dr. Bali, good evening.
Good evening. Thank you for the invitation.
Oh, thank you, Dr. Bali. You know how much I enjoy working with you. And one of the things that you and I have been talking about almost for a year and a half is the patients that come and see you and come and see other doctors. A woman that is pregnant, that is going to give birth, that is going to be pregnant for 9 months. What advice is it that you would like to give her?
Well, there are many things that we need to tell to a woman that is already pregnant. Really, we really would like that this woman don't come for the first time when they are already pregnant. The ideal situation is that this woman come before for a pre-conceptional visit in which we can talk about prevention of diabetes, prevention of increased weight, to place her in certain substances that we know now that are important to be taken before they get pregnant, like folic acid and vitamin D. So the ideal situation is that women understand that they should go to the obstetrician not when they are already pregnant, but when they are planning to get pregnant. The problem in the United States is that most of our pregnancies are unplanned pregnancies. That is almost 75% of our pregnancies are unplanned. So, but in the general and the common scenario, the situation is that the first time that we see our patients, the most important thing that I need to emphasize in South Florida is the diet. We are Latin American people and American people are accustomed in this area to think that it's very important to increase the weight during the pregnancy based on the myth that to be well nourished will be something positive for the development of the baby. And really the situation is exactly the opposite. In our area, the less a pregnant woman increases their weight, the better usually is the outcome of that pregnancy. So it's difficult to go against the cultural standards of our society, especially in our Latin American community, because they are totally convinced that the higher weight you have, the better health you have. So that is one of the first points. The other points, of course, include new situations that can affect not only the mother but also the baby, like the decrease in vitamin D that now we are so aware that is happening in the pregnant population. Usually almost 70 to 75% of pregnant women are deficient in vitamin D, which is an important nutrient for the baby and for the mother in this stage. Of course, in our area, the Zika test is a new tool, a new lab that we need to include in what we call the OB panel, which is all the labs that we request in the first visit of a pregnant woman. The regular obstetric panel include, of course, tests of urine, blood, to know the hemoglobin, the white blood counts, looking for signs of infection or signs of anemia or signs of different type of hemoglobin that affect some women. An ultrasound to see if the baby is already in the viable in the moment in which we can see the baby, which usually is between 6 and 7 weeks. We usually request an ultrasound, and other tests that have to do especially with the genetic area, trying to rule out any genetic disease. Presently, we have increased this area in a very important way with new tests that really help us, the physicians and the mother, and of course the baby, to rule out so many genetic diseases that we can be affected with. And all these new tests really rule out more than a thousand diseases. So all these tests need to take place in the first visit. Usually we advise the woman regarding exercise. That is another point that most of the women don't consider. They consider that once you are pregnant, you should keep a sedentary life, which is not at all a good advice. Women need to exercise every day, pregnant or not pregnant, but if they are pregnant, with more reasons, because that we know increase the better outcome. So the first visits are around those general issues to confirm that the baby is viable, that it's alive, and to control during the first trimester, control the conditions that usually make the woman to lose the babies in this at this time. 75% of all pregnant human pregnancies are lost between the conception and the term. So most of the human pregnancies are lost, and only 25% of all conceptions really reach term and produce an alive baby. So, and most of those losses occur in the first trimester. So during this time, it's important to have a close eye on the pregnant woman. Once she passed the 12, 14, 16 weeks, you can be a little more secure about the viability and the maintenance of the pregnancy within normal limits.
No, Dr. Baldwin, I'm really happy that you mentioned everything that you have, because you and I have been working on stories together now for the last year and a half, and I've really learned a tremendous amount from you. And I know that especially in our community, and I know it's hard to believe for maybe some of the people that are listening to us this evening or watching us this evening, that women wait until the last minute to go see a gynecologist when they're about to give, or sometimes they even show up when they're about to give birth because they didn't think it was important to go see their doctor. Also about, you touched upon the diet, which is very important. And all the women should know that they should be eating healthy and not be overweight. Because one of the discussions that you and I have had is that women think that the heavier they get, the better it's going to be for the baby.
Yes, there are studies inclusively, and unfortunately, this is not well known by people, including physicians. There are studies that shows. I'm sorry, I am in front of a lady delivering now.
Oh, you're delivering now. Okay, I remember you told me that you were going to be delivering, and that's okay. If you have to go, we totally understand.
Okay, but I want to tell you that there are studies that shows that the more the woman increases her weight, the higher the possibility of the baby be a big baby. And a British study demonstrated that that babies who are big in weight are the people who die early in life from myocardial infarction between 40 and 50 years. So women need to know that to have a big baby is not a good thing.
That's right.
Exactly the opposite. probably that is the best message that I can give you at this time.
Thank you, Dr. Bali. I know you have to go because you're about to deliver a baby.
Yeah. Okay. Okay. Thank you so much.
Thank you, Dr. Bali. Well, you've had it. This evening, we've had two of our doctors, Dr. Miguel Diaz from Palmetto General Hospital, who was with us for the first 15 minutes of the show, and he had to go and do a procedure. And our second doctor, once again, is Dr. Dominguez Valley, who is a gynecologist, OBGYN doctor at Hialeah Hospital. They're both amazing physicians, and Dr. Bali called us from the delivery room, but he felt that it was important to share his message and share his knowledge with all of you. Our next doctor is going to be Dr. Lance Simpkins, and we'll wait for him to call. But before he does, I wanted to share some information. Florida Medical Center is going to be having a health fair, and this health fair is going to be taking place on Thursday, April 20th at noon, from noon to 2 p.m. And it is to come and just have an interactive questions with the staff and with insurance providers. We have Blue Cross Blue Shield, HealthSun, WellCare, Aetna, United Healthcare, Simply Healthcare, Medica, and Preferred Care partners. Many times when people come to the hospitals, they want to know what their insurance is going to cover, what is it that's going to take place, how is it that they have to do their paperwork. And this is a good source of a lecture where you can come and gather your knowledge and bring your notepad, take notes, because we are going to have some experts there talking about that. If you would like to RSVP for this event, that once again is going to take place Thursday, April 20th at noon, from noon to 2 p.m., you can call 855-828-7604. 855-828-7604. The other thing that I wanted to mention is that all of our hospitals, Palmetto, that Tenet owns, which is in South Florida, and in Miami, Fort Lauderdale, primarily that area, is a Palmetto General Hospital, Hialeah Hospital, Coral Gables Hospital, Florida Medical Center, and North Shore Medical Center. You can always log on to the website so you can look and see what types of lectures are going to be taking place. We always put them out in the community newspapers and send them out in the community. We also promote them on our social media pages because we like to be connected with the community so the community knows what's going on at each area hospital. I wanted to mention that at Florida Medical Center, we have two lectures that are coming up. One lecture is going to be on March 29th at noon with Dr. Lance Simpkins. Once again, he's an interventional cardiologist, and it's going to be taking place at FMC Auditorium. There's going to be light lunch is going to be served, and you can call 855-828-7604. Let me repeat that number again, 855-828-7604. The other doctor that's going to be speaking is Dr. Jessica Okun. Dr. Jessica Okun is a neurological surgeon, and she is going to be speaking Friday, March 31st at 12 p.m. at the FMC Auditorium. Light lunch will be served, and the phone number to come and make a reservation so you can come is 855-828-7604. The other thing I wanted to mention before we have Dr. Simpkins on with us tonight is that if you visit our websites, you can go to an area where we have that's called testimonials. And we have many of our patients that we have served, that we have taken care of, that we have helped healed, that have been so happy with their care and have really felt compelled to share their story with you and with the community. So if you go onto the tab and look for testimonials, you could read about patients that have come to the hospital that we have taken care of and that have really been happy with the care that they have received from the staff and from the physicians that have taken care of them. Let's take a moment and take a break right now as we wait for Dr. Simpkins to call, because we're going to have a very interesting conversation with him in the second half hour.
I make a dinner for me and my girlfriend. We ate, we enjoyed. The dinner was very good. She was ready to go to sleep. I said, okay, I'm going to stay on the couch a little bit to watch TV. I started to feel something in my throat, like I was choking. And all of a sudden I feel the pain, the sharp pain, like it's somebody put a knife in your back and open and do like this. That was when I called my girlfriend. I said, you have to take me to the hospital. I couldn't die. When they were doing the test, they saw something was weird. My valve was ripped. I said, God, please help me to get out of this. Dr. Bayo was on call. He was who performed my surgery. I describe like an angel. I describe like he was there to do that for me. My girlfriend, my son, he told me when they saw him getting out from the operation room, he was sweating. He was tired to be there for 10 hours. For me, it's unbelievable. I can walk, I can exercise a little bit, and I can drink red one, that light red one. Of course, 1 glass or 2 glasses, no more. I see the life different. And I want to see my granddaughter to grow and my son to get old. So I wanna live. I think that God gave me one more chance in life, and I had to take advantage of this.
Tenet Florida Physician Services is a multi-specialty physician group providing care to the communities of Palm Beach, Broward, and Miami-Dade since 2007. The TFPS team is committed to delivering quality care. Our mission is to improve the quality of life of everyone who walks through our doors. Today, we are proud to be one of the largest and most respected physician networks in the area. To learn more about Tenet Florida Physician Services, visit tfpsdocs.com. That's tfpsdocs.com. Or to find a doctor, call 1-866-654-2362.
You are listening to Doctors Are People Too with David DiPino, who shows us the human side of medical doctors in the community. If you have a question for our guest, call into the show at 888-565-1470. Now, let's get back to the fun side of doctors and show that they are people too.
Good evening, South Florida. My name is Patty Villa, and I'm filling in for Dave DiPino, who is off this evening. You're listening to Doctors Are People Too. And tonight, in the second half hour, we have with us Dr. Lance Simpkins from Florida Medical Center. Dr. Simpkins, how are you?
I'm good. How are you?
Great. Thank you for being on with us. Dr. Simpkins is a cardiologist and an interventional cardiologist at Florida Medical Center. Dr. Simpkins, before we put you live on air, I was mentioning that you are going to be having a lecture on March 29th in the auditorium at Florida Medical Center. Can you tell us a little bit about what you're going to be talking about?
So what I've been asked to speak about more and more recently is the connection between not only cardiovascular disease but general health and weight management. And weight management has become a huge challenge nationwide and worldwide recently, recognized to be just impacting our health, our economy, and it's just incredibly important. The good news is that more and more doctors are starting to recognize this and really take the time to learn more about what is real and what is smart in the approach to managing people's risk factors and helping them when it's appropriate to get to a healthy weight and maintain it.
And, I'm really glad that you mentioned that. And when we spoke a few days ago, you were telling me that this is your passion, that you want to educate people on this. And it's interesting that you mentioned, because the first 15 minutes of the show, we had Dr. Miguel Diaz from Palmetto General Hospital. And he was mentioning also the obesity and how that's affecting the population in his area. We also had Dr. Dominguez Bali that touched upon that, who's a OBGYN doctor at Hialeah Hospital. And he touched upon the obesity as well. And now here we're going to be talking to you about it, because this is your passion. You're the Chief Wellness Officer at Florida Medical Center. And what is it that you want people to know about obesity, and how can they control their weight?
So the very first part of my message, and the most important part for people to begin to understand, is that this is not a lifestyle choice. There has been far too long a sense of blame and shame for people who struggle with their weight. And if this was a very small part of our community who simply chose to live this way, I could understand that approach. But when we are now approaching 70% of our country either overweight or obese, it is clear that we are not stupid.
Right.
We are not lazy. We are not stupid. We are very, very educated, very, very motivated, very smart society. And people that struggle with this, it is far more complicated than just a simple lifestyle choice. And in 2013, the American Medical Association finally responded to the pressure of all of the information that we have to finally label obesity as a disease in and of itself. And that's helped. That's helped us appreciate this and really start to approach this from a smart medical standpoint.
And I know that, and I know that you and I talked about fad diets, and people are always looking for the latest diet, what can help them lose the most weight in the quickest amount of time. Can you share your knowledge about fad diets, what works and what doesn't?
So, fad diets are what we hear about on TV, what we read about on the internet, what we see in popular magazines, and they change all the time. Now, that doesn't mean they don't work. Some people lose weight on some diets that they read about online and magazines. Some people lose weight more traditional ways. There are many, many ways to go about it. Their biggest problem is false claims. And what people's misconceptions are when they simply read on the internet that, this is the latest and greatest, and this worked great for this movie star, and it becomes very confusing what's real, and people really don't know where to go for reliable information. I'm happy to say that I began getting into this about 5 years ago when I struggled myself a little bit with my weight, when I tore my knee playing racquetball and had some surgery and put on 8 pounds. Nobody cries for me. But it bothered me, and I really struggled, and I could not get it off. And it wasn't for 6 months that I finally stumbled into a structured eating plan that helped me to get back to my high school weight, actually, and really allowed me to feel much better than I had in years. But what I learned was that I was excited about it. I tried sharing this with my patients, and what I learned was that there's no such thing as one diet that fixes everything. People are very different, and people respond differently to different approaches. And the reality is that individuals have to find out what works best for them, and that's critical. To do that, they have to know from their doctors what is shown to be safe and effective and actually works. And about 4 or 5 years ago, a group of doctors who were very much dedicated to this fight of obesity got together and created the American Board of Obesity Medicine. And in 2012, they actually gave the first board certification examination. And what that really means is that this is not just fad diets. What board certification means is that a physician has studied this field and this approach to understand what has been shown safe and effective clearly in the medical literature, in peer-reviewed, published medical journals. So this is not something that you will see on an infomercial. This is not something that you will see on the internet. This is very difficult because industry trumps all in the internet, where wherever the money in advertising goes is what people see the most of. Right. But doctors who study this need to be objective. We have a responsibility to our patients. And so what we do is we study this, and basically I've narrowed it down to a kind of simple series of options, including whole food approaches, where people just have to pick a kind of a macronutrient approach, whether it's low calorie or low fat or low carb. And I have my own personal bias and concepts and observations, I'll say, about it that has led me to certain preferences on that. Then there are structured eating plans, which really plan your meals out, so there's very little to guess. It's very structured, and you pretty much know exactly how many calories a day you're eating. That typically uses portion-controlled meal replacements, which are actually proven to be the most reliable for predictable weight loss. The third category is medications. Now, I make it clear to my patients is that there's really no medication for weight loss. There are no weight loss drugs. What there are medications that help control appetite. And that's where I really take the time and let people know that this is not their fault. This is genetics. This is our brain chemistry where we evolved over thousands and thousands of years for survival, and the people that were most fit were the ones who had the urge to eat extra, to store extra fat so that when there wasn't enough food around, they wouldn't starve to death. And the people who didn't eat extra and didn't have that drive, they did not have reserves, and they did die during the winter. And I do believe that's why 2/3 of our country now and above is overweight or obese. This is our natural genetics, our natural brain chemistry that we are now having to fight. What previously was an advantage is now a disadvantage and is actually hurting us and killing us in many instances. And that's the third category. And then finally, bariatric procedures, where previously as a doctor I said, oh, that's crazy, that's extreme, that's risky. Now that I've studied this and I understand the statistics on each and every surgery, I will tell you that they are absolutely reasonable approaches for weight management for some people. So all of these are possibilities, and it gets even more complicated when we learn that some of the medications that we've been using for routine medical care actually have both advantages for weight and disadvantages. Some of the medications that I had been using, I did not realize were actually weight retaining. So some of our medications that we're using to treat the diseases are actually leading to more weight gain. And I think it's important that more and more doctors are studying this and understanding these concepts.
No, Dr. Simpkins, and I'm really glad that, because that was going to be one of my questions this evening, is about the board certification. And you've explained it so well, because a lot of people don't understand what that is, especially if they don't even work in the health field. And, we were talking about the country being overweight, the patients that you're seeing that are coming in, and many of them are overweight. If people in our country don't get this situation and this, experience out of in control, where do you see the country and where do you see our community going?
It's not even where do you see, it's actually recognizing where we are now before even talking about where we see it going. Mm-hmm. So what has really been a call to action for me is adults, this is an epidemic, and it is worldwide. It's not just in the United States, but it's now becoming an epidemic for our children. And as a father and somebody who cares about our future generations, what I have learned is that the Institute of Medicine has predicted that after the year 2000, if someone was born, they have a 1 in 3 chance of being diabetic as an adult. So every child born after the year 2000 has a 1 out of 3 chance of being a diabetic as an adult. That is far more than what we have now, and it is scary because of all of the diseases that come along with the diabetes. It's not only scary medically, it's unaffordable medically, and it's going to break the bank. So to me, doing all this hard work as an interventional cardiologist, waking up at 3 o'clock in the morning to take care of people's heart attacks and put stents in and opening arteries and doing all this hard work to keep people alive, and then see that we're losing this battle long term is just unacceptable to me. And I feel that we absolutely need to look at the prevention side and help people to make health choices for themselves to get healthier, to alleviate that. And also, again, not doom and gloom, and I'm sorry to interrupt, Patty, but just the important thing before I forget is that as a cardiologist, of course, the diabetes and heart disease and strokes are what we worry about the most. But what many people don't realize is that the weight brings on all types of different diseases of all organ systems in the body. And the major one that people need to be aware of is cancer.
And go ahead.
Yeah. No, there have been, as of last year, 18 types of cancer found higher risk in obese individuals than normal weight, either higher risk of developing the cancers or more resistant to treatment. And they predict by the Institute of Medicine that by the year 2030, there will be an additional 500,000 cases of cancer in the country per year diagnosed based on the obesity alone. more than would have been otherwise.
So, and when we were talking to Dr. Diaz, he was mentioning that, and I've been learning this since I spent a lot of time at Palmetto General Hospital as well, is that a lot of the cardiologists there are seeing, patients in their 30s and 40s, something that perhaps many years ago we didn't see. So what kind of, age range are you seeing, and what is it that you're telling the patients that you're seeing, and what advice is it that you're giving them?
So I am seeing younger and younger patients, and we're seeing more and more young diabetics, more and more people with heart disease at a young age, more people winding up in the emergency rooms. And what I've learned, though, is I can't really tell them anything. The only thing I can tell them is what all of this means,
right?
And all I can do is share my knowledge and my concerns for them long term.
Yes.
But only the individual can make up their mind when and if this is important enough to do something about, because it's not easy. There's no such thing as a magical diet that's going to cure you. It is a lifelong relationship with food that must be met as a challenge for each and every individual to do this properly. Some people will need the help of medication. Some people will need the help of surgery. Some people just need to have some good direction to find out what will work for them. But what is clear is that people need this information and have to clearly correlate what has not been recognized and as a major, major risk for the future.
And, when you mentioned diabetes, that touches close to home, because my father was a diabetic, and so was my grandmother, and I have other cousins that are diabetic. What is it that you can tell once you're diagnosed with diabetes? What is it that you could tell those people in order for them to live a healthier lifestyle?
So clearly anyone with diabetes certainly is counseled by their doctor about diet and exercise and the importance of that. That you can't just package them all into one class, because some diabetics are diet and weight related and some are not. Some are more genetic, some are more related to pancreatic dysfunction primarily, without being secondary to diet or overweight. The majority, however, of adult diabetics in this country are weight-related. And that is something that is absolutely addressable and approachable. And what we know is that when people do get to a healthier weight, their risk of all of the comorbidities of diabetes is reduced. And even it's important with diabetics to know which medications you're on, because that is one of the classes where certain diabetic medications actually lead to retaining weight, where others are actually quite useful to help with appetite suppression and weight loss. So there is definitely knowledge to be gained there by a lot of doctors to really help guide them on which medications are best.
Now, I mentioned tonight you're an interventional cardiologist. You're very active at Florida Medical Center. I know that you get called in the middle of the night. You work late. You work weekends. You're helping our community, and you're saving lives in our community. Why is obesity the subject? Because you have so much passion for it. What was it that resonated in you, to help people in the community? Is it just because of what you were seeing, or is it because it triggered something when you were in school?
Honestly, I am very, very proud to be part of this interventional cardiology community. We have technologies now to save lives with people that have heart attacks at any time of the day or night. We have technology to do minimally invasive surgery to correct dysfunctional valves, leaky valves. Amazing technology. From day one when I became interested in cardiology, I was fascinated by the technology, and I remain so. It is amazing, and I am blessed to be in this community and in this partnership and actually part of this system where we have a regional network of specialists that we refer to back and forth within our Tenet system. Having said that, as I've learned and been in this community for 25 years, what I've seen is that the technology keeps getting better, and yet we're losing the battle. The risk of these diseases is not getting better, and the country is not getting healthier. And I think, it's great that we have these options available to treat people when they're ill, But to me, what is so needed and so powerful is to start working more on the prevention side. And doctors can't do that alone. It has to be a partnership with their patients.
That's right.
Patients have to take some degree of responsibility to say, this is my life, and I own it, and I am going to do something about it. I think that sharing the message to let them know that this is not their fault that this has happened. This is not about blame. This is not a personality flaw. It allows them the confidence to partner with their healthcare providers to really take approaches to really help get them to a healthier place. And then to the next level to share that with our children to get them healthier.
That's right. And I'm really glad that you talked about that and you touched upon that, because that's one of the questions that I wanted to ask you is, one of the things that I've learned at working at Florida Medical Center is, we have a lot of great people working there, a lot of people that are passionate about helping others and making them healthy. Before you came on the air, I was talking about, excuse me, I was talking about, the listeners that we have and the viewers that we have going on our website, reading testimonials that we have of patients that we've taken care of and that they have left our hospital healthy and happy and they're doing well. And I know I have met several of them that have even come back to visit. But something that has changed in the last few years is that team approach. And you touched upon that. You said how one doctor helps the other. You refer a patient to them. They send the patient back to you. It's like several people involved with that one person making them healthy. Can you talk about that?
Yeah, sure. So, traditionally in the past, every hospital kind of wants their market share in South Florida. And we would all be competing with each other to have the latest and greatest technologies. Unfortunately, to do that, you have to have a certain volume of patients at each hospital to justify that technology and that expense. And really, it was not cost effective. What Tenet has done, and I was cautiously optimistic at first, but now seeing it grow, they really have created this cardiovascular network across the Tri-County area in South Florida, where really at a moment's notice with any cardiac condition, we have colleagues that are experts in every field that we can reach out to and communicate with, and I do this all the time. I was actually delighted that one of my patients who was really in pretty bad shape with a very badly diseased mitral valve, where traditionally open heart surgery was the only way to fix it, was just referred to be put on a trial up at Delray Medical Center to receive a stented valve through a catheter into her mitral valve position, and actually had that done last week and did beautifully. And I was just delighted that with a phone call I could get that process started, refer her to people that are known nationally for this work, and have a great outcome and great communication and great feedback. It's nice to truly feel like you're part of a collaborative effort. And I really love that.
And I love that too. And that's one of the things that I love about doing what I do, doing my job, and working in public relations and doing that for the 5 hospitals in the Miami and Broward area, because I also see that interaction and I see the way that you all work together. And I've even worked with Dr. Manny, who works primarily in the Palm Beach area, when he's come to Palmetto to help the cardiology team there. And he one day said, 4 eyes are better than 2. And I've never forgotten that. And I just love seeing that team approach in the especially in the cardiology line of how all the doctors work together.
I couldn't agree more, and I don't like naming too many names, but Bridge Manny is a special guy, and
yes,
he is exactly the one who helped me arrange this for my patient, and just provides top-notch care, and it's just great. I'm proud to be affiliated with people that are passionate about their work.
Yes, absolutely. And one of the things that you mentioned was the mitral valve. Can you explain what that is? Because not everybody knows what a mitral valve procedure is.
Sure. So the heart is made up of 4 chambers, 2 collecting chambers and the 2 pumping chambers on the right and left side. The most common areas of diseased valves that we hear about are the aortic valve and the mitral valve. The aortic valve is what lets the blood out of the heart from the pumping chamber to go to the rest of the body. Traditionally, when that valve became degenerated, we would have to operate on that valve with open heart surgery. Up until, I'd say, over the past 5 to 10 years, it has become increasingly more common to hear about a catheter-based placement of an aortic valve without open heart surgery. It's what we call a stented valve. It means it's a valve that's delivered kind of collapsed in a tube and placed in the heart actually as the heart is beating, with the patient not under general anesthesia. At first, it was only accepted for the highest risk patients who basically were too high risk for surgery, the very elderly, the very frail, and it was kind of a last-ditch effort for someone who was going to just otherwise die. And they had good success. It has evolved with the generations of the stents and the success and the experience to now where we are sending healthier and healthier patients to be considered for this procedure. It's still being investigated in healthier patients, but many of us in the field are very confident that this is the way of the future. Less invasive, more technology-based approaches to really minimize the amount of trauma to the body to fix these valves. Now, that was the aortic valve. The mitral valve, which is a little, if you will, deeper in the heart, harder to reach, if you will, with these catheters, was basically not considered something that would be catheter-based until the last several years. And first in Europe, we started hearing about some reports in Europe where they're doing these procedures. And now they've brought it here to the United States on trial. It's not standard of care. It's not going to be offered to somebody who walks in off of the street, but it's being investigated as part of a trial, the Tendyne trial, and it's being compared to traditional surgery and to see which outcomes are best. And again, for people that are not surgical candidates, we basically just did the best we could with medications. But now we're having these non-surgical options for people that are high risk. And my hope is, again, just as it was with the aortic valve, that over time we will have even healthier patients receive these options, because my hope, and I don't know this yet, but my hope is that these procedures will turn out and be proven to be safe and effective as surgery, giving more options to people who need them.
Dr. Simpkins, we have a few more minutes, and something that I wanted to ask you, we see a lot of commercials regarding AFib. Can you explain what AFib is to our listeners and to our viewers?
Sure. So AFib, you probably would hear many different opinions on what AFib is.
Yes.
AFib is an irregular rhythm of the heart. Right. The heart has a metronome, for you piano players, in the heart that sets the timer for every beat. In some people, because usually of other factors that put stress on the heart, sometimes it can happen alone and of itself. The heart starts beating without any coordination. The heart is made up of billions and billions of cells. I think everybody could appreciate that. Mm-hmm. Each one of those cells has the potential to start a heartbeat, but typically they stay quiet. They don't do that. And just this metronome, this sinus node, is where the heartbeats come from. Sometimes in the atrium there are other spots that start beating, and sometimes they do it in a very uncoordinated fashion. And this lack of coordination doesn't allow those upper chambers to squeeze because they're chaotic. There's no uniform beat. When the beat finally reaches the lower chambers, they're still able to contract relatively normally, but the upper chambers don't. So people can live with that from the heart function standpoint. The risk, however, is that those upper chambers, when they're beating dysfunctionally in an uncoordinated way, they don't circulate the blood from all of the corners of those upper chambers, and little pools of blood can form blood clots. And the blood clots lead to strokes. And that's where the real danger is. And people develop life-threatening strokes, which are often irreversible, and it's a catastrophe when it happens. So we put people on blood thinners, and blood thinners themselves, like Coumadin, have other major long-term risks and problems. And so it is a major concern, and we're seeing quite a bit of this. there is actually quite a clear relationship to obesity and sleep apnea and other medical problems, hypertension, many things, valve disease that can lead to the atrial fibrillation. Nonetheless, we have ways to treat it. But again, part of this consortium of experts in cardiology, we have now ways to electrically stimulate the heart and use freezing techniques to eliminate those pathways that cause the irregularity. We have devices that can plug off the areas of the heart that can lead to the clots, specifically the Watchman device, which we are part of in our system, using that technology and developing newer and newer medications and technologies to control this. The fibrillation itself, the irregularity, is more of a nuisance, and that can be controlled with medications. It's the clots and the strokes that are really what cause us headaches and can cause catastrophes in people's lives. And but again, it's great that we have this partnership and more technology available.
Right. Well, Dr. Simpkins, we are out of time, but I want to tell you it is a true honor to have you on the show tonight. You have been a wealth of knowledge. Just everything you have said, we can learn from, and we hope to have you on again in the future. Thank you, and have a good night.
Thank you so much, Maddie. Have a good night.
You've been listening and watching Doctors Are People Too. Dave DiPino will be back next week. Thank you.
Thank you for listening and watching Doctors Are People Too with David DiPino. Join us next week for more in-depth views on what doctors are all about and how they spend their free time. All shows can be seen on amp2.tv. And if you have questions you want answered on the air, call 866-224-5422 and leave a message that can be read on the air. The opinion